Hello, health psychology students. Good to see all your faces. Welcome. I hope that you have read the syllabus and participated in Flipgrid. It's neat getting to know you all by watching the Flipgrid posts. Please do try to post and introduce yourself in the small group forums, but I think that I've got some issues going on. I've had some emails coming through where I might need to work on the small groups and make sure that I got the technology straight on my side. So if that's not working, don't worry about that. Do we have any questions about the class before I get started and on the updated lecture?
The dog. He was like staring at the same time as the dog.
Okay, if you are not speaking, if you all could please mute your mics because I'm hearing a little bit of background noise, but please feel free if you've got any questions as we go through lecture today to unmute your mic and just ask your question. And I will try to pause as we go into lecture to give you an opportunity for those questions. All righty. So this is a live lecture because I am trying to update the information on what is going on in our healthcare system. So I'll give you an intro today, and then we'll pick up with the rest of this lecture in the next couple of recorded lectures. So I'm Dr. Denise Martz. I'm a clinical health psychologist. Health psychology is my baby. I also teach a women's health course. And so even though it's online and we're not face-to-face, I'm excited to teach you this semester. Okay. I am assuming, because I know it is true, many of you, based on the backgrounds of your majors and watching the Flipgrids, many of you might be taking this course because you want your own personal health to benefit from it, which is awesome. But then many of you in here also intend to go on to professional school and to become some type of healthcare provider. And so I'm teaching this class with the direct application that ideally I'm helping you get knowledge and some basic skills that will benefit your future career if you're going to be a future healthcare provider. And so the big picture here is that our emotions, also called affect, our cognition, also called our thoughts, and our behavior, what we do, they're all critical to health and they're all intertwined. And so primarily this semester, I'm going to follow cognitive behavioral therapy, CBT. And then I will also primarily follow ACT, ACT, which we call it ACT though, which is acceptance and commitment therapy. And both of these modern day ways of helping people think about how our behavior, feelings, and thoughts are all intertwined. And so one way, if they're all intertwined, if we want to help somebody with their behavior, or if we want to help somebody with their emotions, if they're really struggling, let's say they're depressed, then we're going to tackle one of the others to try to, in a triangular way, influence all of these. Okay, so for personal health or for future healthcare, I want us to get in just some textbook definitions so that when I use these terms, everybody remembers what I am talking about. So integrative medicine, this really is a class in integrative medicine. It's called health psychology. It really is about integrating medicine. And if we think about traditional, in the United States, traditional biomedical model, which is how medicine tends to be practiced in the United States. It's changing, but it tends to be that biomedical model, meaning you're sick, you go to the doctor, get a diagnosis, get a prescription, or you get a surgery or a procedure to fix whatever ails you. But integrative medicine takes that traditional biomedical model, sometimes called allopathic medicine, and it integrates other types of therapies. So it integrates psychologists, it integrates dietitians, it integrates physical therapists, it integrates occupational therapy. Many of you are pre a lot of those other programs. And so the integration is the traditional medicine and these other types of therapies. Complementary and alternative medicine is the complementary things are when we pull in the other areas. So when we pull in exercise, physiology into cardiac rehab program, that is complementary. So instead of treating somebody after a heart attack, say with statin meds and blood pressure lowering meds, we send them to a cardiac rehab program where they're getting exercise, medically supervised, dietitian, psychologist. That would be the complement. The alternative medicine is instead of reaching for traditional medicine, like let's say reaching for a medication to lower blood pressure, the person engages in an alternative therapies. So let's say they start exercising on their own. Let's say they start seeing a psychologist for stress management. And let's say that exercise and that stress management bring their blood pressure down. They don't need the medication. So in that situation, it's an alternative to medical treatment. When we use it with the medical treatment, we integrate it, it's complementary. To give some legitimacy to this, I want you all to know that one of the branches of the National Institute of Health is NCAM. And NCAM is the National Center for Complementary and Alternative Medicine. So it's the NIH branch for integrative medicine, or CAM. And what this organization does is it funds really good scientific research on integrative medicine. So our federal government, NIH, has a branch dedicated to this. Public health is the branch of medicine for public health is affiliated with hygiene, epidemiology, disease prevention, and management. And public health is tax-based funded. And you all know that during this pandemic, public health departments everywhere are working very, very hard. Our local health department, as an example, is hiring more contact tracers. We've had a class offered in psychology over the summer, and we're offering it again this fall, a class in contact tracing. And a lot of those students who took the class over the summer are getting hired into our local public health department to try to help trace contacts for people who are infected right now. Healthcare insurance in the United States would be things like, I've got Blue Cross Blue Shield through the university plan, Cigna, those are various kinds of public healthcare insurance. And our public healthcare are things like Medicaid, which is state-based. Our taxes that go to the state of North Carolina support our Medicaid. And Medicaid serves individuals, children and adults below the poverty line. And the poverty line moves around in different states. It's defined by a state. So our poverty line could be different than the poverty line as defined in Tennessee, as an example. But Medicaid is state-based for poor people. Medicare is more federally funded, so more of our federal taxes, for people 65 and older, or people with a registered disability. And about 50% of our healthcare in the US is Medicare or Medicaid. And about another 50% is private, like Blue Cross Blue Shield. Now, in our country, our healthcare system and our public healthcare system do not talk to one another very much. They are not integrally linked. And that's part of the reason why we've had some struggles in the pandemic in the US, because now public health has had to kick into gear. Some of us were well insured, some of us were not well insured in terms of insurance coverage. We don't have great coordination like a lot of our sister countries have, where their public health and their socialized medicine or their universal health care, they're all the government. So they've been well integrated and cooperating and working together over time. Those countries have actually fared a little bit better with some of the pandemic control than our country. And this is a piece, there's more to it, but this is a piece to it. All right, questions here before I move on, because I know this is a very busy slide.
Are these slides going to be posted on As You Learn?
The slides will not, but the lectures will be. So
okay.
If you want to go back, I mean, you can see them again is what I'm getting at. And if you want to see them again and mute me, you can. If you don't need to. Okay.
Thank you.
Other questions? Okay. Health psychology relative to other sciences. I know you all weren't born in 1970. You probably, I guess you were eggs in your mom at that time. But health psychology in terms of psychological fields and other science fields is very new. It's very young and developed in 1978. I'm a member of the division of the American Psychological Association that is health psychology. And it merges psychology, medicine, and public health. We are here to study the causes, etiology means causes, study the causes of disease scientifically. We are here to promote health, and we are here to prevent illness. And as a science, we are also quite politically active. And so we do a lot to promote public health policy and things to improve our healthcare system. So it's not unusual for health psychologists to say lobby politically to contact our representatives and advocate for consumer health. I am a big advocate for integrative healthcare because I know the scientific data on how much more successful it is in helping people. And if there's ever a time where there's, say, a bill that's been proposed that would add to integration, I contact my representatives, get them on the phone or email and advocate for our healthcare system and our culture. So any questions about what is, I'm going to keep defining this here, but I just wanted to let you know that the birth of this field really happened in 1978. So questions here? Okay. I also want to define what is behavioral medicine, because when I work with my medical patients and what I do with them would be considered to be behavioral medicine. The behavior is the medicine. So this is the application of psychology and other social, behavioral, or spiritual services that are evidence-based, meaning they are scientific. They are informed by science. We practice science. To help people who are diseased, and I'm going to pause here for a second because I know you all know the word disease. Disease usually means you've got a medical illness, okay? You've got a diagnosis, you've got a medical illness. But I want us to focus on the root of this word, diseased, because this is about mind-body here. When you have disease, you are diseased. When you have disease, you are usually stressed and upset or in pain or uncomfortable. As well as, I want us to pay attention to the flip side of that bidirectional relationship. When we are diseased, when we are upset, when we are suffering, that drives medical illness. Okay? So the psychology of suffering can drive the medical illness, and the medical illness can drive the psychological suffering. So disease is a word for a reason. Okay? There are a variety of professionals who practice integrative medicine. A lot of health psychologists, a lot of physicians, a lot of physical therapists, dietitians. There are a lot of different professionals that practice this. And in behavioral medicine, we usually work at what is considered to be secondary or tertiary prevention levels. So let's walk through the levels of prevention. Primary prevention is when we do something when we are healthy to keep us healthy. So for those of you who eat healthfully and you exercise on a regular basis, that's primary prevention for illness and psychological disorders. It makes us psychologically healthier, physically healthier to exercise and eat well. Secondary prevention is when we have signs or symptoms of disease, but it's not full blown. So an example would be being diagnosed with high blood pressure, but you haven't had a stroke or a heart attack. But untreated high blood pressure that goes on long enough will lead to a stroke or a heart attack. So secondary, you're treating signs or symptoms of disease, trying to prevent full-blown disease. Tertiary prevention is what we normally call treatment or rehab. Tertiary prevention, a person has full-blown disease. They have a medical diagnosis, like type 2 diabetes. And the treatment that we give to them is trying to prevent that disease from worsening, and it's ultimately trying to prevent them from dying of that disease. Okay? So in behavioral medicine, we usually practice at secondary or tertiary prevention levels. True health psychologists that are doing interventions or treatments, usually out in the community, to keep healthy people healthy, that would be primary prevention. Any questions here? Okay, so in integrative medicine, we think and we practice out of what is called a biopsychosocial spiritual model. And so let's walk through the biopsychosocial spiritual model here. It's beyond the biomedical model, which is the traditional medical model we have here in the US, that involves diagnosing using medications, procedures, and surgeries. And integrative medicine embraces this biopsychosocial spiritual model. And I just want us to kind of think about these levels. Many of you have had classes in these different levels. So on we think biologically, we think about the whole human being. Biologically, we think about organs. We think the organs boil down into cells, and each organs that have different functions. Those cells are made up of chemicals, and there's physics to those cells. So we could go way back down into even nanophysics here. Psychology, we focus on emotions or affect. We focus on cognition, which are thought patterns, and we focus on behavior. Socially, we're going to be thinking about relationships, and I'm going to spend a good bit of time on social support and relationships this semester, because relationships are absolutely critical to our health. We are interdependent creatures. And then we could think about our institutions. So this could be our family system. This could be our church synagogue. It could be, we are all mountaineers. We're all here at ASU, as an example, would be institutions. And then it rises all the way up to the spiritual level. And the spiritual level could mean religion, a practice religion like Judaism, Islam, Christianity. But we also could boil that back a little bit and think about a sense of meaning and purpose. We're going to talk about acceptance and commitment therapy, ACT, this semester, and ACT is really focused on having people identify their values and making sure that they're leading a values-driven life. And so that would fit very well into a sense of spiritual purpose. And then it could be a sense of, spiritually, a sense of connection. So if you believe in God, Allah, higher power, it would be that I feel connected to this higher power. It could be, I know many of you have come to ASU because you love the beautiful outdoors. It could be, I like to get out into nature as many days a week that I possibly can and exercise or experience nature. And there's that sense with connection with nature. I love it when I'm out on a hiking path and a mama deer and her baby deer cross the path and I go, oh, like I'm a part of, this is where they live and I'm a part of it, that sense of connection. So again, biopsychospiritual model, when we think about treating our clients or patients out of this model, we're thinking about treating a whole human being. Okay. It's not just a diagnosis and a medication, strep throat, you got penicillin. There is a person here who has that strep throat, and that person has a history and that person has a future, and they may have good relationships, bad relationships. They may feel connected, they may not feel connected, but we think about treating the whole person. So any questions here? Okay, thank you for the head nods. That helps me when people are like, yay or nay. Okay. I can see about 6 of you right now. If I try to see all of you right now, I can't see my PowerPoint. So the 6 of you, you're live. Thank you. Yeah. Okay. All right. We are going to go way, way, way back in time because I want to contextualize our healthcare problems before the pandemic. And then I want to contextualize our healthcare problems now since the pandemic. And so obviously starting in summer session for me, this class, at least the intro lecture, has had a dramatic change. So way back in 1900s, when none of us were alive and none of us were even eggs in our mama's ovaries, this was the leading cause of death for people at the time. The majority of people were dying of pneumonia and the flu. Number 2 was tuberculosis, an infectious lung disease where people basically couldn't breathe and died. Intestinal disease, drank bad water, ate bad vermin, sort of rotted from the inside out. That's a harsh way to go, but died of intestinal disease. Heart disease was number 4 on the list. And a lot of that had to do with people's lifestyle behavior was very different back in the 1900s. And people tended not to live long enough to necessarily have heart attacks or strokes, which was number 5 on the list. Nephritis was kidney disease. Accidents was very low in 1900. And I want us to think about technology or lack thereof that we have now today back in 1900s. Accidents was very low on the list because people didn't move fast enough in cars, trucks, airplanes, trains. They didn't move fast enough that if they came to an abrupt halt, it killed them. Make some sense? If any of you seen the movie One, my sons made me watch it. I thought it was pretty stupid, but there's a scene in it where they're riding, they've got an ox pulling a carriage, and the dude, like, it's moving really slow, but the dude's like, whoa, way too fast, whoa, way too fast. And it's like, no, it was moving really slow. We can tolerate high speeds nowadays because we're used to riding around in cars or airplanes. Cancer, pretty low on the list. A lot of this because it was hard to diagnose cancer back then. A lot of it also had to do with we're more prone to developing cancer the older that we get, and people weren't necessarily living as long. In theory, every single woman in this class, if we lived long enough, will eventually get breast cancer. You dudes in this class, if you live long enough, theoretically, every single one of you would get prostate cancer. It's just a normal part of aging, hormonal type of aging, and how that affects tissues for us. Senility, which nowadays we usually, the DSM calls it dementia, and most of us know this more by the one cause of dementia or senility, Alzheimer's disease. Again, pretty low on the list because people weren't necessarily living long enough, and people led a healthier lifestyle back in 1900. Diphtheria was also another infectious disease. For the most part in the 1900s, it was communicable infectious diseases that killed people. Got it? That's the take-home point here. Okay. Prior to the pandemic, and this is coming out of Center for Disease Control data in 2014, there's a lag in data for the Center for Disease Control to collect it, make sure it's accurate before it gets posted up on their site for us to consume. The #1 cause of death in the United States was coronary heart disease, and that was 50% of all deaths. Don't worry so much about the raw numbers. I've got the raw numbers here just to give you a little bit of sort of proportions. Coronary heart disease, #1 cause of death for men and women in the US. Women just get coronary heart disease later than men. We're protected up until menopause with our natural hormones. It's a myth that breast cancer is the #1 cause of death. That is not accurate. That's just what a lot of people believe. After that, second leading cause of death is cancer, and that's 23% of all deaths is cancer. 50% of men will have cancer, and 33% of women will have cancer in our lifetime. Okay. So 23% of all deaths. But I want us to come over here, and I want us to focus on the causes of the #1 and #2 cause of death. 65% of these two leading causes of death are attributable to cigarette smoking, diet, and lack of exercise, which we call sedentary behavior. So 3 lifestyle behaviors that are common lifestyle behaviors in the United States account for 65% of #1 and #2 cause of death prior to the pandemic. This is why, my friends, we have a class in health psychology. Because we psychologists, we're the ones that specialize in understanding human and changing human behavior. Okay? If behavior is driving our disability and our death, then we got to get in there and work on human behavior. Any questions about that? I want you all to absorb that context for why we have the field of health psychology. Okay. There are other lifestyle behaviors that certainly are going to impact these deaths. Poor social support, poor connection, poor relationships with others. People with poor relationships get sicker. They die sooner than people who are well connected. Stress is going to impact this. One's socioeconomic status, which is basically a function of income and education. Low SES people get these diseases earlier and more frequently than people who have privilege, who are high education, higher income, have access to health insurance. Number 3 cause of death, COPD, chronic obstructive pulmonary disease. These are usually the people that are on oxygen tanks. And if they're in pulmonary rehab program, they recover really slowly. People in a cardiac rehab program after a heart attack recover much faster than pulmonary patients. So this is when lungs have usually been damaged by cigarette smoking, or people have had lung damage because they've come into contact with airborne asbestos, or radon. We've got radon in the mountains. My home here has radon mitigation because we're sitting on a rock on a crawl space that had radon in it. So we've got a pipe that takes the radon gas up into the air so we're not breathing it in my home, as an example. Number 4 cause of death is unintentional injury, which is also sometimes just called accidents. Okay, so motor vehicle accident deaths would be an example of unintentional injury. And there are behaviors involved in that. The leading behavior, does anybody want to guess leading behavior in a unintentional car accident is what?
Drinking and driving.
That'll do it. You're definitely right. I can't see you. That'll definitely do it, but it's not the most common cause of car accidents.
Texting and driving.
You got it. Yeah. We cannot focus on this baby and focus on the road at the same time. And we can talk and drive a little safer than we can text and drive, but even when we're talking and driving, that impairs us. So the more common stuff is the things like using the phone. Yeah, you got it. You know, drinking and driving is not good. And actually, ironically, as somebody who, I haven't had one in a while, let me knock on some wood, speeding tickets, rarely does normal speeding create car accidents. I mean, reckless driving, if you're going insane, 80 miles an hour down 105, that wouldn't be advised. But normal speeding usually doesn't create too much harm. So whenever I get a ticket and pay my ticket, I'm like, it's life. Okay. Number 5 on the list before the pandemic was cerebrovascular disease, commonly called stroke. And the same risk factors that cause coronary heart disease is the same disease process and the same risk factors that lead to stroke. What ends up, the difference there is when you have clogged arteries to the heart, it could damage your heart, cause a heart attack, kill you from a heart attack. Same damage to the arteries that feed your brain. If they get clogged, it's going to create oxygen deprivation and stroke in your brain. If it's a teeny tiny stroke, you might not even notice it. If it's a huge stroke, you might die immediately. Right? Same disease process. It just ends up where it creates the damage first in what we call this disease outcome. Number 6 on the list is Alzheimer's disease, and we are living longer and we are seeing more dementia and Alzheimer's disease, a bit as a function of living longer in our society. Number 7 on the list, diabetes, and we'll spend a whole lecture on diabetes, particularly type 2 diabetes, which is lifestyle driven. Type 2 diabetes, stress, lack of exercise, unhealthful eating, obesity, lots of different lifestyle factors driving up our diabetes. 8th on the list, influenza and pneumonia. And remember, that was number 1 on the list in 1900s. Nowadays, we're not seeing as many deaths from influenza and pneumonia for a couple of different reasons. One, many of us get vaccinated, and CDC just came out and is really encouraging people to get flu vaccines this year. I know we're worried about COVID, but we need to be worried about influenza. We don't want to get sick. Then we'd have to go get tested, find out, is this coronavirus? Is it the flu? We don't want to get sick and be using healthcare, especially we don't want to get sick and have influenza drop into pneumonia and need to be hospitalized because we need those hospital beds for coronavirus patients. So much lower. Another reason why influenza and pneumonia is lower on the list is that many of us get the flu, and I've even had pneumonia once. It was horrible. And we're miserable. We're absolutely miserable and sick. But if we have a healthy immune system, we get over it. Okay. Back in the 1900s, there were lots of other things that were compromising people. So it was number 1 cause of death. Kidney disease you saw back in 1900s, pretty low on the list. We've got nephritis here. Diabetes is actually driving a lot of our kidney disease nowadays. And then 10th on the list, and keep in mind, this is for everybody in the US. So adults in the US, suicide is 10th on the list. And suicide certainly has some behavioral factors. Usually we've got untreated mental illness. So somebody who has a psychological disorder who's not getting effective treatment. Access to lethal means, which we are proud owners of a lot of guns here in the United States. And the reality of it is we've got higher suicide rates because we've got more suicidal people who have access to firearms. Other risk factors for suicide would be significant stress in one's life. We know, for example, right now, just to contextualize this, people of color in the United States, even students of color here at Appalachian State, are experiencing a fight and are experiencing stress and are experiencing a feel of systemic racism. There's more stress for those particular individuals than, say, somebody like me who has white privilege, as an example. So there's contextual factors, environmental factors, and then there are behavioral factors for all of these leading causes of death. Now, all of this is pre-pandemic. So any questions here? Let me give you all a chance to ask a question.
For number 4, like the unintentional injury, does that kind of also count towards like natural disasters, or I guess also kind of bringing up like, school shootings or public shootings, like where would that fall? I mean, it's probably not on the list, but.
The natural disasters, I don't think fit in there. And the school shootings and things like that, I think they fall into murder from firearms.
Okay.
Yeah, I don't think that's rolled into the unintentional injury, but I think you're getting at a good point. Let me go to the next slide, and y'all can still ask. I can go back if you want me to, but I do want to talk about, because you just brought up homicide. Center for Disease Control, all of this data, again, pre-pandemic. So they define youth in the CDC. Children are 0 to 14. Young people, and most of you in this class are young people. I wish I was young people still, but that's been gone a while. You're in this age range, so I want to present your leading causes of death just to contextualize this a little bit. Unintentional injuries is your #1 cause of death for young people. And most of those are motor vehicle accidents. And you dudes here in the class, you pay more for your car insurance with a comparable car than a gal with that same car in this class. Why is that? Why do you all have to pay more for car insurance than gals?
Isn't it because
typically, I believe men are.
Let's hear the guy speak. I hear a guy and a gal.
I believe it's because typically we have higher rates of like reckless driving. Typically, I think there's speeding and some other impulsive behavioral issues.
You got it. My oldest son had so many speeding tickets, he had to take a class. And if he got one more, he had to leave the country if he wanted to drive, because he had so many speeding tickets. He's got a lead foot, and now he's got a sports car, but he's learned to be more careful now that he's married and doesn't want to hurt somebody else. Yeah, it's actuarial data. You guys get into more accidents, you're more costly to insure your car insurance than the gals. #2 for young people is suicide. And I can tell you, we've got several professors in the psychology department. We've got Dr. Kurt Michael and Dr. J.P. Jameson that are absolute experts in treatment and prevention of suicide. And one of the things that I've been trained in and I've learned over time, I have known for a long time how to calculate suicidal risk. But actually, we're not very good at calculating risk because most suicides happen quite impulsively. And what we've gotten really good at is, it's called counseling against lethal means, CALM. It is helping individuals when they are having suicidal ideation remove the means. So that could mean double locking up firearms and separating firearms from ammunition. That could mean asking a person to give their firearms. The police department will take and keep your firearms safely for you while you're going through a suicidal crisis until you are well, and then you can get your firearms back. It might mean, I've had clients before who are suicidal, who have medications in their homes or their apartments that if taken in an overdose would kill them. So we either double lock up the meds or have somebody else unlock the meds to give that to that person when it's time for the prescription meds. Or I've even done things like have people keep their meds in their glove compartment locked up in their car so that overnight, if they're feeling really bad, they've got the medications that they need to take for their illness, but they don't have a whole store of medications in front of them should they get really depressed and suicidal. And that counseling against lethal means is very effective at preventing suicides. So since somebody mentioned homicide on the slide before, it's number 3 for young people, but does anybody want to take a guess of what demographic is most vulnerable to homicide as a victim, getting shot and killed by somebody else?
In terms of mass shooting?
Say that again, I could barely hear.
Is that in terms of like mass shootings?
Mass shootings, you got it. But the demographic that's most at risk, and this is no surprise with what's going on politically, contextually in our nation right now, it's Black men. Black men are most at risk for murder, whether it be from police brutality or it be, especially if they're surrounded by gang activity. If they live in an environment that involves gang activity, that's the #1 cause for young black men in the US. But yeah, we've got the school shootings in there also. Number 4 on the list for young people is cancer, and number 5 on the list is heart disease. We are seeing type 2 diabetes, heart disease, and strokes happening earlier and earlier because of lifestyle behavior, even in young people in the United States. Okay, so lots and lots of behaviors involved in all of these, or socioeconomic status, or our environment, or our demographics here. All of this is before the pandemic, okay? And what I'm gonna do throughout the whole semester is I'm gonna focus on lifestyle behavior post and pre-pandemic. Now, in order for me to show you these, I believe I'm gonna try to turn this on, and I'm gonna then stop my share, and I'm gonna ask you if you could see it, because I think I have to stop share and move to a different screen. Let me try it. Could you see it? Could you see a graph pop up?
No.
Okay, thank you for telling me that. Okay, here's what I'm going to do. I will restart it. Stop. I am going to, oops. Sorry, I got to talk to myself when I do this because I'm juggling like 5 screens. Okay, let me share my web-based screen here. Can somebody give me a yes if you can see this?
Yes.
Thank you. Okay, this is, this goes up to, you see down here, 4/27/20. And it starts in March. And I want to start it all over. Let me go back. Okay. See COVID down here? We had 1 case March 1st in the US. So this is US data, not world data. The world data, the COVID looks just the same in the world data, but the leading cause of death worldwide is malaria. It's not coronary heart disease. So March 27th, April, bouncing around a little bit there. And then by April 27th, boom, leading cause of death for us here in the United States. Okay, so within 2 months, it took over leading cause of death in the US. Now, I want you to understand though, that the COVID data is live data. The heart disease, cancer, accidents, all the stuff that I presented to you before is dated data. It was the averages in the United States pre-pandemic. What we don't know yet is live how COVID compares to these other causes of death. There are still people dying of diabetes and heart disease and stroke nowadays. And we just don't know how right now those causes of death compare to the COVID causes of death. And also know, as an example, a risk factor, if you contract coronavirus, if you have type 2 diabetes, having the type 2 diabetes, you're a lot more likely to die from the virus than if, say, you don't have type 2 diabetes. So any questions here on this interactive graph and what it means? So April 27th, we were at 2,470. This is deaths. It's not cases, it's deaths. Questions here?
Sorry, Dr. Martz, I do. Can you hear me okay?
Yeah, I can.
Okay. So if someone was to get COVID and they did have like all of those, like a pre-existing condition, and they did happen to die from, I guess, the condition being exacerbated, would that be then, would the cause of death be like coronavirus, or would it be like type 2 diabetes or whatever the case may be?
The epidemiologists and the health departments and all of that are trying to track both of those. So
Okay.
like as a major cause of coronavirus death right now is pneumonia. People get pneumonia and then they die of complications from pneumonia, but the coronavirus was the added complicating piece. So they're trying to keep track of was this person infected, and then what other diagnoses did they have? Because exactly, Jordan, this is the information that we need.
Okay.
Because again,
Thank
so
you.
the data that I'm showing you is current and then it's past. We don't have it all merged yet because there's a time lag in that.
Got it. Okay, thank you.
Okay. Now let me go back to my PowerPoint, and I'll come back to you all here in just a minute. Yeah, let me go ahead and share my screen back to the PowerPoint. Okay, so you saw the interactive map, and you saw that in April 27th here, we had 2,470 deaths in the United States. The Center for Disease Control is tracking this. As of yesterday, August 17th, we had 5,430,232 deaths in the US. I mean, I'm sorry, those were cases. Sorry, the 5.5 million cases. 168,696 deaths. So this is how far we've come from August 17th from April 17th. And know that you can look up this, you have to unshare the screen. Let me go back. I just want to show you this dashboard where you all can take a look at this. So. Okay, let me share my screen again to the website. Just know that Center for Disease Control is updating this data daily. There's been some politics about Center for Disease Control. Public health departments have to report this information, and so we get local health department data, and then they push that data up through the Center for Disease Control. Some of the most recent politics about this is the federal government wanting the data to come to them first, and then they would disperse that data to the Center for Disease Control. The concern about that is the public health departments have always push their data like sexually transmitted infections and stuff like that directly to the Center for Disease Control. We've got epidemiologists who know how to manage that data and publish that data truthfully to the public. The concern with the current administration asking for that data first is that there could be potential tampering with the data, and that what the Americans do not, and the scientists and the medical doctors do not have access to, is the most accurate data coming through the CDC like we've always pushed that data. Okay, so just to get a feel for what that was about. Okay.
I had a question
Okay.
involving like the politics behind like the COVID deaths and stuff.
Oh, we're gonna go there in a minute, but go ahead and ask the question.
I just wanted to ask if like those death numbers were the ones that like died of COVID in a hospital, or if they were all of them reported, because I read an article about how hospitals were getting like trauma patients who died in like car accidents who happened to test positive for COVID and then labeling it a COVID death because they get a certain amount of money for every COVID death.
Yeah, I don't know. I don't know how accurate that is, but again, ideally, health departments are making, and in conjunction with hospitals, doing the best we can with accurate reporting. So a motor vehicle accident where a person was not symptomatic but tested positive for COVID should actually be coded as a case of COVID and
Yeah.
a cause of death, a motor vehicle accident.
Yeah.
And I would really hope that our hospitals and our health departments are trying to report as accurately and honestly as possible. But I'm with you. I've heard some of that concern, and worries about the funding issue with that.
Yeah, because my mom works in the Duke health department, like coding it, and she's seen a lot of those cases labeled as COVID, but then she reads the actual doctor's transcripts, and they like coming through the trauma wing, like from a car accident.
Oh, that is unfortunate if that's what's going on. Yeah. Okay, back to the PowerPoint. Okay, I want you to know that the North Carolina Department of Health and Human Services, they also have a dashboard, and they're keeping as accurate as possible, up-to-date information for us. And I want to show you this dashboard where we look at confirmed cases, death, test, hospitalization, etc. So again, I'm going to stop my share here and go over to web-based. Sorry for all this bouncing around, but it just will not let me do this within the Zoom altogether. Okay, so this is the North Carolina dashboard. And so this is, they say here it's been updated about an hour and a half ago. This is our death toll. This is our confirmed cases, our testing, our currently hospitalized. Just know that that dashboard exists. Should you all wish to use it, take a look at it. I want to go further, and I want to talk about, let me share the PowerPoint again. I want to talk about this thing called staying ahead of the curve and what that means. What we have tried to do from a public health standpoint, and some regions have done this better than other regions, and different states have done it better. When we talk about flattening the curve, what we're talking about is taking the number of COVID cases and spreading them out over time, so that if people get infected and they get symptomatic, and especially if they need healthcare, and especially if they need hospitalization, and especially beyond that, if they need a ventilator, which are precious right now, that the cases are spread out so that the number of cases are low enough over time that our healthcare system, the way it is structured in our different communities, can handle it. If, on the other hand, we don't take the protective measures and we get this number of cases above and beyond the healthcare system, a lot of these people are going to die if they don't get ICU and they don't get ventilators. Okay, so do you have any question? When we talk about flattening the curve, of course we want to prevent infection. Of course we want to treat people and help keep them from dying when they're infected. But the flattening the curve is really about not having these spikes in infection, keeping the curve flattened, spread out over time, so that we've got the healthcare capacity to take care of people when they need it. Any questions on that? Okay. I also want you to know, that the Center for Disease Control has a COVID tracker by state, if you want to sort of look at, and it even will go more granular, so you can look at states, and then you could look at regions. We've fared pretty well here in the high country, as an example, relative to Raleigh and Charlotte. Things will be changing with return of students to campus. Not you all, I know everybody here is going to be safe, but we're going to see a changing pattern in the high country. And we're more crowded than ever before this time of the year, because we've got people with second homes, right? We got people coming up here vacationing. We've got students back. We are packed here in Boone, and you can just tell 3 weeks ago, driving in Boone was nothing like driving in Boone this morning. So, okay, let's keep going. I also want you to know, this is UNC TV, and I'm not going to play any of this because there's nothing necessarily streaming right now, but I want you to know of it as a resource. It's been really helpful for me to watch some of these presentations over the summer. So we have Governor Cooper. They oftentimes will have leader politicians from the House and the state Senate. Dr. Mandy Cohen is our Secretary of Health. I have had a girl crush on Dr. Mandy Cohen this summer. What a smart woman who she's so articulate and can really speak the data in very practical ways that normal human beings can understand. She doesn't talk doctor talk, she talks to human beings and boils down the information. Here is information, and you all have been fed this. I know you know all of this kind of stuff coming out of Appalachian Health Department, coming out of Center for Disease Control, all the stuff we're supposed to be doing, the social distancing, the hand washing. I'll show you a picture of how you're supposed to cough into your elbow. It doesn't work nearly as well when you don't have clothing because the cloth is what really absorbs it. Staying away from people who are sick, trying not to touch your face. Boy, I've learned how much I like to touch my face for reasons I have no idea. This summer, I've been trying to keep from doing that. I have learned to do this though, instead of this thing, I do this now. Cleaning and disinfecting surfaces, all that stuff, you all know this. So the pattern from 1900 until pre-pandemic changed dramatically. We went from, in the 1900s, interestingly, infectious disease and less lifestyle disease. Pre-pandemic, in modern day times, we went to lifestyle disease. So the heart disease, the cancer, the COPD, the stroke, lifestyle driven. And now we're back into a pattern where we've got the lifestyle driven stuff still happening. And on top of it, we've got the pandemic happening. So let's spend a little bit of time talking about coronavirus. So the coronaviruses are actually a large family of viruses, and they live very regularly in mammals and certain birds. So there are a lot of coronaviruses out there that have not affected humans that are just naturally occurring in mammals and birds. The SARS coronavirus 2 translation is one of the SARS. So the severe acute respiratory syndrome coronaviruses named number 2. So it's a sequel, our COVID-19 is a sequel to SARS-CoV. And it's also very similar to the coronavirus that emerged in the Middle East that we nicknamed MERS. Okay. So these coronaviruses are not new to infecting human beings. Okay, this one is new, which is why you keep hearing the word novel coronavirus or novel COVID-19 or novel CoV-2, that type of thing. It is brand new. And it was thought to jump from bats to humans in China, probably through an intermediary organism. And some thoughts on that type of thing is that bats are vampires. You all know that. We like our vampire movies and dramas and that type of thing. So bats are vampires. They go and they feed off of blood of other animals. And then if human beings eat those animals, particularly if those animals have been out in an open market, meaning they haven't been refrigerated or frozen, they're out in an open market where essentially they're kind of rotting. When people buy that food and eat it, it can jump from the animal into the human. Just like it jumps from human to human. It could be airborne, or they eat it and they eat it not fully cooked, or it hasn't been stored and they get it internally, that type of thing. So that zoomatic transformation, does that make some sense to you all? Can I see some nods? And if you've got any questions, ask your questions. We're going to come back to the bats here in a bit. So the actual virus is the SARS-CoV-2 that causes what we call the infection COVID-19. The 19 came from the fact that we think this was born, this zoomatic transmission happened in 2019, and then it became a real health problem in 2020 for us. Okay, does that make some sense? So it's much like the virus HIV that causes AIDS. So AIDS is the illness, HIV is the virus. Any questions here? Okay. Before the pandemic, the pattern, the change, the big change was it was less infectious disease. Now we're way back up on infectious disease. More chronic disease, meaning when people had disease, they had it for a long period of time. So like cardiovascular disease, which causes heart attacks and stroke. People have signs and symptoms of cardiovascular disease at a much younger age than before they have their heart attack or their stroke. And so chronic, meaning they are sick for a long period of time. If they are sick and they know it and they have access to healthcare, they are accessing healthcare and putting a drain on the healthcare system for a long period of time. That's going to amount to a lot of expense in healthcare, which is important to all of us financially. There was a lot more lifestyle influence. The lifestyle influence is still happening, even though we're in a pandemic. And was a lot more disease revealed in the elderly. So we're seeing cases of dementia, particularly caused by Alzheimer's disease, at an all-time high, as an example. And a lot of that is because people are simply living long enough, and even Alzheimer's has lifestyle factors driving it. People living long enough to be revealed in the elderly. So all of this changing pattern was pre-pandemic, but all of this is still happening. Okay, a lot of this is still happening at this point. Any questions here?
So with, you said that with people living longer, like cases of Alzheimer's and whatnot are increasing. So is it like kind of a cycle that healthcare is getting better, and so people are living longer, then it's also draining healthcare services, I guess?
It's draining healthcare services. Somewhere in here in this lecture, not today, but you're going to see it in the other intro lectures, is an argument that our healthcare system is actually not doing a great job of keeping a lot of people healthy, because people are falling through the cracks. We're relying too much on biomedical medicine, and we haven't been relying enough on the biopsychosocial, spiritual, integrative medicine. And in theory, I think all of you in here could kind of relate that we all want to live long lives. You know, if we're happy and healthy, we want to live long lives. But add to that, we want to live healthy long lives. Like, I don't know about you all, but I don't want to spend the last 3 years of my life blind in a diaper, harnessed in a nursing home bed. I hope I don't go out that way, you know? But in some ways, like, the longer we live, the more we're going to see that some kind of disability happening that chips away at quality of life for a lot of people. So Gotcha. It really is, one of the take-home points of this class is we want to enhance quality of life as well as length of life for everybody. That's the ultimate goal for integrated medicine.
Gotcha. Thank you.
Sure. Any other questions before I move on? So this is the pattern pre-pandemic. Okay. Major things have happened. So I want to just kind of catch us up on what's been going on in science, epidemiology, politics here. So the big leap that happened that changed the pattern between 1900s and 2019, one of the biggest scientific advances was the development of immunizations. Years ago, I took a hike up in the Finger Lakes of New York, and we came upon this really, really old graveyard. And I was fascinated by the tombstones in the graveyard, because it would have, you know, name of mom, name of dad, and you would see all these little tombstones of all these babies that died, or 1-year-olds or 2-year-olds or 3-year-olds. You know, these families would have like 10 kids in hopes that 2 would grow into adulthood, because they were losing so many of their little ones to these infectious diseases that nowadays we get immunized against and we don't die of. Okay, big, huge leap in public health. Some things that aren't very romantic whatsoever, but boy, count your blessings, you know, every now and then count your blessings, that we have learned how to keep our poop and our urine out of our drinking water in the United States. Now, developed countries, this is still an issue. Undeveloped, still an issue. In developed countries, we've gotten pretty good at this. Very interesting. I do not know if Boone is doing this, but I know they're tracking this down at Clemson. They are tracking the virus in sewage sanitation. And you can tell by tracking the virus and the load of the virus in sewage, in sewage, so like Boone sewage, you could estimate how many cases and the increase or decrease that is going on in Boone just by the sewage, which is kind of interesting, I think. But our ability to do this has again, not very romantic, but nice. I kind of like having pure drinking water when I drink my water. Other things that have happened in that 100 years, food preservation, which has been really, really good for us. We can go shopping, bring food home, refrigerate it, or it can be stored in our cabinets and last a long, 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 long time. The downside of that is some of the stuff that we do for food preservation in processed food, we've now learned is not real healthy for us. So ideally fresh food, food that we can bring home and eat right away, or food that we can refrigerate and eat before it spoils in refrigeration or freezer, is better than food with a lot of preservatives in it. But it is still a big leap that we made in that 100 years. Lots and lots of behavioral lifestyle change for people in the US. People in the 1900s moved around with their own physical body a lot. They ate whole foods because that's all they had access to. So they ate well. They tended to live in communities with other people. They had to move for survival. They got lots of exercise. Nowadays, people are not eating the same way. They're not eating as healthily. A lot of people are the majority of people are sedentary. And then some other things that happen is just preventative health care. So if you have access, if you're a privileged person and you have insurance, I just had my yearly wellness check a couple weeks ago and got all the girly stuff and all the other stuff done. And my insurance company even does that for me for free because they want me to go in and get the preventative health care. Okay, so any questions about the old big changes in that 100 years for anybody? Okay, so in 2020, you all are living in history. This is my first pandemic too. There have been a few others, that have floated through like Ebola and SARS and MERS, but it's not really affected my life at all. I know this is brand new for all of you. So let's ask the question, were we prepared for the pandemic? And the answer, after our administration knew what was going on in China, and then we had outbreaks happening like in Italy and other countries, we did not act on it. We did not act on it nearly enough. I'm not trying to be political here. I'm trying to be factual as a scientist. Dr. Anthony Fauci, I've got a boy crush on this dude now because he's just so articulate, and he's been around with us serving presidencies ever since AIDS, HIV and AIDS. He said, no, we had the information and we didn't act on it soon enough. I wish we would have acted on it earlier. In terms of preparing vaccines, the answer is more of a yes. But interestingly, most of the momentum that we have in the pharmaceutical companies like Moderna, Novia, the companies that have been working on these vaccines, has come from private funding. So many of you know of Bill and Melinda Gates, a la Microsoft fortune. They have a whole foundation where they poured thousands of dollars into healthcare. They're trying to wipe out malaria in the whole world, as an example. So they use some of their extra money in these foundations for healthcare issues. And the Gates Foundation has been working on multiple viruses for multiple, not just COVID-19. They've been working on others because they have been assisting with other people who have funded. I want you to know about what's going on here in the politics here. So when you watch the Netflix on the coronavirus, there's a couple of Netflix posted up there. I want you to watch them, take notes from them. You're going to learn a little bit more about Dr. Peter Daszak's EcoHealth organization. So this organization had National Institute of Health funding. They've also had some private funding. And what this particular epidemiologist has been doing, he's got a team over in China. This is part of the reason why there was the China conspiracy, that the Chinese had this virus and unleashed it on the world trying to be mean to everybody, which is a conspiracy. The lab is over in China. And what they were doing is they would send these epidemiologists carefully into these caves, and over time they take these bats and they swab them and they look at what viruses these bats are carrying. So when we talk about family of coronaviruses, other viruses, they would find early on in these bats, they would take the swabs back to the lab and code the genome of the virus. And because they were monitoring the bats, they had a leap up or a step up on knowing what these bats could transmit to the animals, therefore knowing what those animals could zoomatically transmit to the humans. Got it? That was very valuable information. EcoHealth knew the genome of coronavirus 2 well before we started hearing about it infecting humans. That gave them a leg up on we need to know the genome to get started on that very lengthy vaccine process or very lengthy medication process. Now, for no reason at all, and unprecedented, as a scientist, I am very offended by this. If I had National Institute of Health funding, which I don't for my research, if I worked hard enough and was good enough of a scientist to get NIH health funding for my research, and my research was ongoing, if a politician stepped in and pulled my funding, putting a halt to my research, that would be horrible. That the NIH has never done that before. They only pull funding when research has been found to be harmful, and then they stop the research because of the potential harm. They've never pulled it for political reasons. The current federal administration, for no reason, has pulled the NIH funding for EcoHealth. The reason this terrifies me is that there are viruses that are going to be infecting humans in the future that now we don't know about. We don't know their genome because this project, they're trying to get private funding, they're trying to get back up and operating, but they lost a tremendous amount of their NIH funding. So if you thought coronavirus 19 was scary, I don't mean to scare you and bring you down and make you depressed today. There's some viruses coming our way that we are not going to have the same leg up on. Yeah, Vivian, go ahead and go. Yeah, it's scary. It's really scary. Okay. Okay. So again, watch that Netflix Explained to sort of see more about Dr. Daszak and his organization. When it came to having the healthcare personal protective PPE, I know we're trying to say community protective wear too, and ventilator production, no, we were not at all prepared. We're not at all prepared even if we get an effective vaccine. We don't have the manufacturing of the vials to store vaccine in play to be able to, even if we could make the vaccine, we don't have the vials manufactured to push the vaccines out to health departments for people to be able to obtain the vaccine. Even beyond that, the United States sold a bunch of ventilators to Russia instead of keeping those ventilators here on the home front and disseminating them to hospitals that were saying, hey, we've got trends, we've got more people getting infected, we're going to need more ventilators. We've not been very good at policing the distribution of these materials on the home front. Okay, Watauga Hospital, I believe, has either 10 or 11 ventilators. We are going to be in trouble if we've got people needing intensive care. When it came to medications to treat, the Federal Drug Administration and multiple pharmaceutical companies, the answer is a yes. But again, it is because we knew the genome. Because of EcoHealth, these companies knew the genome, and they have been tracking these viruses and trying to get a leg up on making these vaccines. Because again, if they make the best vaccine that gets disseminated, these companies are going to make a lot of money. So they're very motivated to be able to do this. And from a public health standpoint, we want them to be able to do this. So we've done better here, okay? We do have some medications that have been helpful. When it came to studying the antibodies, we're early on that, where there are scientists that are monitoring people who've had the infection, who have obviously lived and healed from the infection, and they're studying if they're making antibodies. The scary thing is that it doesn't look like our human body is doing great at this antibody thing. But if for those who do, and we can study the antibodies, if we can take those antibodies and use that for treatments for other people, there's been a long history of science of doing that for disease. So giving people the immune system that will help them fight the virus, that was the immune system that helped somebody naturally fight the virus. So the answer is yes on that. The jury's still out though on the whole antibody process. The thought is, even if we get we need to make antibodies, because if we don't make antibodies for this thing, which I can't control, obviously, vaccines are not going to be very effective, because that's how vaccines work. You get a vaccine, if it's safe and it doesn't harm you in other ways, it creates that specific immunity. If you're exposed to the virus after that, if you've got that specific immunity, even if you catch the virus, you won't get sick because your immune system can take care of it. That's how our vaccines for measles, mumps, all that kind of stuff work. The worrisome thing is that this is first of all, we got to make the antibodies or the vaccines aren't going to work. The other depressing thing is that it seems like this is going to be more like a flu vaccine, where we're going to need to get, even if vaccines work, we're going to have to get it over and over again. It's not going to be the kind of thing like you get your tetanus shot every 10 years, and if you encounter tetanus, you're good to go. It's probably going to be where we're going to need mass production of vaccines because of the regularity in which we need this. Add to that the politics. I know you all are paying attention to the world. We got people saying already, if you come up with a good effective vaccine, I'm not going to get it because I don't believe in vaccines. That's a problem for you and me. If you and me wish to get, if there's an effective vaccine, if we wish to get vaccinated, because we need about, I think it's, don't quote me on this, it's either 60 or 80% that we need to get herd immunity. And herd immunity meaning, like, if it comes into our community, we've got enough people that have either had the virus and have antibodies or been effectively vaccinated that it's not going to be bouncing around all of us and spreading that way. All right, I have covered a lot in this slide. What questions do you have about this slide or what we've talked about? If you have, okay, somebody.
I have a question about EcoHealth. Was there, or like, have there been any viruses in the past that they had discovered and like saved us from being in what we're in now?
Yes, they had a lead on, we just talked about SARS, MERS, Ebola. They had heads up on many other things that have spread. And again, not necessarily catching stuff early, because remember, if these bats have these viruses right now, then the animals have it right now, and it might be jumping to the humans right now. But it's still a heads up in that you get that genome, the scientists get the genome and they start working on treatments and the vaccines.
Thank you.
Other questions?
Did they choose bats to study because they carry so many different diseases?
Yeah, apparently they're pretty germy. Yeah. Stay away from them. Yeah. And they just, mammals that eat mammals tend to eat all of the mammal, if that makes sense.
Oh, yeah.
Except for the bones.
Uh-huh.
Bats suck blood, so it's easy for them to get viruses from mammals, but then it's also easy for them to give the virus through their saliva to the mammal.
Makes sense.
So I guess kind of the ideal thing to study, I guess.
Yeah, because I was wondering, like, why wouldn't they pick, like, pigs who are, like, genetically so close to humans?
You remember swine flu?
Yeah.
Swine flu? That was transmitted, we believe, into pigs and then into humans, and that's why it got called swine flu, as an example. And those animals, like pigs, are critical in phases of the vaccine testing. So before we test these things on humans, they get tested on mammals, and they look for safety and they look for effectiveness and make sure that the mammals are building antibodies. And then they go to small clinical trials of human beings with the vaccine. If human beings aren't dying of harm from the vaccine and they're building up antibodies, then they start doing larger clinical trials. So the human testing happens in phase 3, the animal testing in phase 2, the large scale clinical trials happen in phase 4. And so when we talk about the whole world, the scientists and even our federal government is doing their best to rush along vaccine production. We are doing that. They're giving resources galore to these companies to support vaccine production. But there are reasons why we go through the phases for safety and efficacy.
Yeah.
What we don't want, and this is probably going to need to be a live virus. I don't know, we'll see, but it may not be a dead virus or partial RNA of a virus. It's likely going to be a live virus. So a lot of people who are most vulnerable to getting really ill or dying with coronavirus are the people who won't be able to take a live vaccine because it'll be more dangerous for them. But what we definitely don't want is a vaccine that gives people coronavirus and then kills them.
So I had a question on top of that in your explanation. So there's a lot of talk about people like ending testing on animals, but how would that affect the vaccine approval process if we can't test on animals?
Yeah, I'm all for humane treatment of animals, but this is one of the places where we cannot ethically, I guess we could, we cannot ethically do that kind of level of testing on human beings that we can do on animals. Keep in mind there's IOCs, there's ethical boards on how scientists, when they use animal research, they have to adhere to those ethical guidelines and they have to get that stuff passed before they can ethically launch their research. But in this situation, I don't know if there's a way around that. I mean, there's definitely a way around, say, testing cosmetics and not using animals to,
yeah.
You know, but when it comes to this life-threatening type of thing for humans, I don't have a creative way around it. I don't know if scientists do.
Okay.
Good question, though. Okay, other questions before I move on? I realize I'm over time. I'm going to keep going until I line up with the next recorded lecture, part 2. If you all have to leave and come back and watch this part in the video, feel free. But I've got a few more before I'm going to end this recorded lecture. So post-COVID, dramatic takeover of infectious disease. We've got that transfer from Wuhan, China. I want to talk about how this spreads. And this is one of those places where that 6-foot thing that we've all been trying to follow is a bit arbitrary scientifically. 6 feet's better than 5 feet. It's better than 4 feet. But again, 6 feet's kind of arbitrary. It's something you can talk about with your friends. Wind tunnel studies, there's air kind of studies. A cough releases 3,000 droplets that could be carrying the virus. It travels 50 miles per hour and up to 20 feet. So a cough 20 feet. When I was in the grocery store this morning, one of the personal shoppers was beside me in the veggie aisle and she had the hiccups. And at first, she hiccuped and I was like, oh crap, she just sneezed right by me. But then I realized she had the hiccups, but I still moved myself away from her because I don't know what a hiccup does, but I'm sure it sends some moisture through a mask. A sneeze, sneezes are pretty powerful, getting possible infection out of our body. 30,000 droplets, over 20 feet, traveling 200 miles per hour. You all, this has made me realize, this is the morbid part of me, and which will come out, leak out at times over the semester. This has made me realize I teach in auditoriums. I teach in IG Greer. This class would have been in Blick 114. And if I don't use a microphone, I would get in the classroom and I would project my voice across the auditorium and students could hear me. I'm quite loud. This has made me realize I have been spitting on students all across these years, just spitting all over them. Isn't that disgusting? Ew, ew. Anyways, sorry, previous students. All right, just a breath, 50 to 50,000 droplets, and just speaking, 500 to 500,000 droplets. And singing, you've heard about that choir practice where after the choir practice, the church choir practice, a bunch of people got sick because they were singing. And then when you're singing, you're projecting those droplets as you project your voice. I've also, my friends and I'm an amateur, I'm not a professional, amateur cyclist. My friends and I, we even wear masks when we're cycling because we've seen the wind tunnel data. Runners, because they're breathing heavy, runners drop their droplets 30 feet behind them. Cyclists, we believe, can drop as far as beyond that because cyclists are usually going faster, especially downhill, than runners are going. So we are spreading droplets back. So we're even masking when we're riding. People look at us really funny, and I'm afraid somebody's going to pull a gun on us because they're mad that we're wearing masks on a bike, but that's what the science says. So getting infection is a risk of being exposed to somebody else is droplets, or picking it up, say, on your fingers and then putting it on your eyes or in your mouth if you pick it up on a surface area, times time. And so even things like, it makes sense if you've got to go to the post office and get your mail, get in there, get it quickly, sanitize your hand. Get in the grocery store, have your list, know what you're gonna buy, get in there, get out there as quickly as possible. The longer we spend time with somebody who might be infected, even if they're asymptomatic, the more likely we are going to get infected. So, and the more level of the virus we would get. I felt like I had something else to say and I forgot it. It might come back to me. Oh, indoors. We are so much safer outdoors because of fresh air ventilation. And then even sunlight, we think, has a helpful effect at killing the virus. And it's going to be interesting to see what happens as we move into fall and winter. One of the reasons why flu becomes epidemic level in the winter. First of all, flu virus can live in cold, not moist air longer. It doesn't do well in hot, humid air. But then people move indoors. They're breathing each other's air a lot more indoors in fall, summer, late winter, that type of thing, than, I mean, not summer, than they do in the summer, spring, fall months. The R0 is an important epidemiological statistic that we're tracking, and it's spelled RO, but it's called R0. This is the number of new cases that every one case generates. So we're certainly trying to keep R0 down. That's part of the social distancing, the mask wearing. Right now, as of May, every one case in the US that had it gave it to 2.5 people, okay? Parties, if you think about like the spread, the R0 that would come out of a massive party is way higher than that. You could have one person potentially give it to 30 people in one night at a party. Or I ride my bike around here on Sundays, and there have been churches that have been meeting. Some churches absolutely have not been meeting. Some have built outdoor areas and are meeting outside. But I've seen the churches where they've been meeting indoors on Sundays, as an example. And I drive by there and I'm like, oh no, it takes one person to spread to so many individuals in those situations. All right, lots on this slide. Any questions? I've only got a couple more.
What gets me is the people that are out in public and they pull their mask down to sneeze or cough. Like, I just don't.
That's where it doesn't work. That is, and I get so angry when you see the noses hanging out. It's like, dude, yeah, you know, it's the mouth and the nose, you know, not just over the mouth. Yeah, the pulling it down, or pulling it down to talk on a cell phone. I've seen that one. Pulling it down to cough or sneeze, very dangerous. You know what I've heard? If somebody comes up and gets aggressive with you, if they're mad at you because you have a mask on, a great way to approach it is, dude, I wasn't feeling well and I had a fever this morning. Would you like for me to pull my mask down and cough on you? If they get up in your face. I wore my mask because I wasn't feeling well and had a fever this morning. Shall I cough on you? Or do you want to give me space? Okay, incubation period is the period of time between when a person has contracted the infected load of the virus and the onset of symptoms. And we're estimating about 2 days. So a lot of people are infected and asymptomatic for a good 2 days before they start showing any symptoms, if they ever are going to show symptoms. And again, a lot of people in that time period are asymptomatic, but they're shedding. They are spreading the virus to others without even knowing that they have it. After infection, it tends to last 10 days after the onset of symptoms. So people are averaging if they get sick from it after contracting it, tend to be sick for about 10 days. And then we want to make sure that they're keeping themselves isolated 10 days after the onset of symptoms, or at least 3 days after they've had no fever and no symptoms. So kind of paying attention to this incubation period is important. We know that this virus, it's a stubborn one. It can live on surfaces, which is why we're supposed to be washing hands, sanitizing, wiping down surfaces, doorknobs, light switches, all that kind of stuff. And some of the cruise ships, they've even found the virus still living on surfaces 14 days after everybody disembarked. So that's scary, how long it can last. And then again, transmission there is you touch something and then you put it in your face. I've got my little hand sanitizer in my car door. So as soon as I open up my car door, I do my sanitizer, I get in, take my mask off. So I know that my hands are clean after being out in public. So again, in health psychology, behavioral is absolutely critical to transmission of the virus in this pandemic. It is all about behavior, okay? I want you to read the article that I posted on As You Learn. It's just called How to Avoid COVID Transmission. There's some information I presented in this PowerPoint, but I want you to know the information in that article. So that's a homework as well as the Netflix. Of course, we know about these super spreading events, the parties, the churches, that kind of thing. But interestingly, most cases as of now, people are contracting it. The most common way people are contracting it now is not going to a party necessarily. People are getting it in their home. Somebody's bringing it to them in their home is the most common, okay? Which is why we've got danger when people are out and exposed elsewhere and then they're coming back into the home. I hear we bought a new camper. We did an upgrade of a camper this summer and it's fantastic. Yay, I love camping. But a lot of people are purchasing campers not only for safer travel because flying is less safe or public transportation is less safe, but there are a lot of families have bought campers so the healthcare worker in their family lives in the camper and the rest of the family lives in their home. And then they meet outside and have social distancing family time. I mean, isn't that wild that we've come to that where healthcare providers have had to isolate themselves from their family members? Public bathrooms are dangerous. They are high touch areas. People are touching the sinks, that kind of thing. And then here's the gross thing. I'm just gonna lay this gross thing out there. Do you all know that we shed, if we've got the virus, we shed it in our feces? And did you know when you flush in a toilet that without putting the lid down, and this is what's scary about campus right now, most toilets on campus don't have lids, that feces and that virus gets aerosoled. So keep your mask on in a public bathroom, folks. Take your wipes, wipe down stuff before you touch it, but wear your mask even when you are using a public restroom in case there's virus floating in the air from somebody else's feces, which is a disgusting thought to have, but it's a possibility of transmission. 44% of infected asymptomatic people, this is scary, can be shedding the virus for 5 days. Even before, if they get symptoms, even before they get the symptoms. And it's just it's most contagious right before they get symptomatic. So the asymptomatic person was most infectious yesterday, but back 5 days, which is why in contact tracing that we've talked about, we've got a course ongoing right now. If you want to take it, see if you can get into it, because public health departments are going to be hiring more and more contact tracers for a long time. They might call you up and tell you when you were exposed. They can't tell you who you were exposed to. That's a violation of confidentiality. Most people can kind of go, oh, I was in Harris Teeter yesterday. If you said I was exposed yesterday, that must have been it, because otherwise I was at home. Or you were exposed on Sunday. It's like, I went to church with everybody, inside a building on Sunday. That's what they're doing in the contact tracing, trying to figure out where people got it. The super spreading events, this is no surprise, the meat packing plants. We had a huge outbreak in Wilkesboro over the summer from the Tyson's chicken packing plant. There have been meat packing plants out west where you've had this massive spreads. Weddings, funerals, birthdays. I've got a niece who postponed her wedding for a year just because it was going to be in August of this year. Restaurants, we've got some reopening of restaurants, and that's going to be problematic in some cases. If people are working in a environment where they're breathing each other's poor ventilation, they're breathing each other's air. Even in Smith Wright, I'm not teaching any face-to-face classes. They've got spacing going on in the classrooms. They've got the windows open. They've got fans working. They are trying to do everything to keep the ventilation better. The whole university used to recycle its air. The whole university has gone to fresh air. So what's coming into the building is no longer recycled, it's fresh. Doing what we can. Indoor sporting events. My partner's been watching basketball on TV, and it's hilarious to me because there's no crowd sounds. It's the dudes playing basketball, and then you've got the people zooming as the audience. You've got these faces zooming, but there's no clapping, there's no yelling. It is just the weirdest thing. But that's dangerous. Okay, barriers to protecting yourself. You all know this stuff again, the cough, the sneeze. Keep in mind, the cough in the arm doesn't work very well. It's going to bounce if you don't have clothing on. She's not quite close enough, but if she dug in there a little bit more and she coughed actually into the cough, that would be fantastic. If you have a bare elbow, go ahead and cough into your hands as tight as you can, or sneeze into your hands, and then go sanitize or wash your hands immediately. It would even be better to do it and keep them clasped until you can get to the sanitizer, or you can get to try to keep whatever is in there, any of your slobbers, keep them in your hand. The face stuff you all know about. Don't drink Clorox, don't eat pods. That's all a joke. But some people were doing that after information got out this summer. I'm almost done here, folks. I know we're over time. If we look at the status of our health, and we could look at this in the inverse of the status of our illness, 40% of our health is determined by our behavior. Right now in the pandemic, it is probably even higher than that. Okay, we don't have that data yet. There's a time lag. 10% of our health is determined by our access to medical care. So kind of a small part of our total health. But again, it's the access to medical care where we have the haves and the have-nots. The haves tend to be white people of higher socioeconomic status, income, and education. The haves tend to be men. The have-nots tend to be women, children, and people of color, and people of lower SES, who either have poor insurance, they're underinsured, or they have no insurance and really struggle to access the healthcare that they need. Okay, so again, the contribution now, this is old data. The contribution now we don't quite know because of the time lag. All right, here's my magic wand. You all don't need to take notes on this because I'm going to go over and over and over this stuff later on this semester. If we had a magic wand, this is pre-COVID though, I want you to know. And in our magic wand, genie in a bottle, magic wand, whatever it is, we could go out and change one health behavior at a time in the United States that would have the biggest bang for its buck and save more lives and keep people healthier. The first behavior we would want to tackle, again, pre-virus, smoking and vaping and dipping, tobacco use. If we could get everybody off of tobacco use, and now I'll talk about the vaping stuff when we get to the smoking lecture, that would have the biggest impact on the health of people in the US. Number two, and the genie or the magic wand, sedentary lifestyle. People in the United States are way too sedentary. In college campuses, most of you all get more exercise than the real world because you tend to be young and healthy and enjoy your exercise more. Those of you taking my health psych class, probably even more. I've got a selection factor. But second, if we could get people moving and up to the ACLSM guidelines for exercise, we would be a much healthier country. Number three on the magic wand, nutrition. Nutrition is complicated, but if we could boil it down and simplify it, it's basically people in the United States are eating way too many animal products, and we are not eating enough plant-based foods. And we will talk more about this when we cover diabetes, more about this when we cover nutrition. I am a pescatarian. People always want to know if I'm vegan or vegetarian. I don't eat red meat. I stay away from chicken as much as possible. And I just don't like that stuff. I don't like the taste of it. So it's not, it's not necessarily a political thing. But if we could shift people's diet in the US to more plant-based food, even if they don't become vegetarian or vegan, and less animal products, we would have a huge impact on the health of our culture. And then number 4 is alcohol. Magic wand. And I'm not opposed to moderate consumption of alcohol. I like my Chardonnay. But we have a lot of harm caused from excessive alcohol use and alcohol addiction. A lot more so, ironically, when alcohol is legal and things like marijuana is still illegal in a lot of places. Marijuana creates a lot less harm than alcohol does. And then even the way our government has created levels, I'm blocking on the word, not severity, or not scoring. If anybody knows the word, help me. Like a narcotic is a X and a Valium is another. How they've just created the level of harm and the level of security for obtaining those things by prescription doesn't make logical scientific sense. And
Classes of them?
Yes, the way they're classified. Thank you, whoever you are, angel out there, with the word that I couldn't find in my head. Yeah, the way they're classified in their levels. Okay, I am done with lecture. I've got your part 2 of this lecture is going to start right here. And so I'm going to stop my share here today. Thank you for staying over for those of you who could. What questions do you have for me? Whether it be about the way class is being structured now that you've seen it live, about the syllabus. Please read the syllabus carefully. I've been getting a few emails from students who obviously haven't read the syllabus with some questions for me. If you've done Flipgrid, great. If you haven't done Flipgrid, go ahead and do that. If you run into problems, I think there are problems with the small group forums. So I need to work on that. I need to kind of figure out and get those small group forums up and working.
I have a question.
Okay, Samuel.
Okay, so for the PowerPoint won't be on ASU Learn, but the recording will, correct? Like of our Zoom?
Yes. Yes.
Okay.
There are outlines. There are outlines of the PowerPoints up there if you're going to type your notes into the PowerPoint outlines. But I strongly recommend that you handwrite your notes because people learn better that way.
Okay. And how about meetings like actual live sessions? Like, do we have to come to every single one, or like can we just watch the recordings? Like,
you bet. You can, yeah, if you can attend live and you like that, some people like having that structure in their day right now, please do. It's nice for me to be able to see faces when I'm teaching. But if it's inconvenient for you, this is meant to be as flexible as possible to keep students in classes, keep students learning, keeping your college on pace.
So every Tuesday and Thursday, we're going to have a live session from 2 to 3:15, if you choose to join or not.
Oh, y'all, I'm so sorry. I am totally confusing this. I just taught abnormal psych. I'm sorry. I'm confusing you all right now. I did them back to back. So, no, this class will be lecture only from here on out recorded. I'm sorry, Samuel. It's not, yeah.
But there won't be a PowerPoint posted. It's just going to be a lecture video.
Yeah. Okay. You'll see me lecture like you did today. You'll see me lecturing on the PowerPoint. But I don't want you all I don't want anybody looking at the PowerPoints and thinking they've got what they need, because so many of the things that I talk about, and especially when we get further in the semester and I'm giving you all case studies as an example, those case studies are going to bring stuff to light for you. So I want students not only viewing the PowerPoints, I want you viewing them and listening. But yeah, from here on out, we will be recorded. But please, if you want to access me or Shraddha is my graduate assistant, my new doctoral student. She's wonderful. She has 8 office hours a week. If you want to meet with her, if you want to meet with me, I've got my office hours from 2 to 4, Tuesday, Thursdays in my Zoom room. Please come and see me. I highly recommend after you take your first exam, if you do not do as well as you wanted to, that you see Shraddha or me and let us pull up your exam and go over what you missed and trace what you missed back to the origin of that problem, whatever that problem may have been. Okay. I'll give you a quick example. Don't read the study guide at the bottom of my syllabus for study strategies. I had a student over the summer, she took her first exam the class was all online. She did poorly, so I reached out to her and I asked to meet with her in Zoom. And I asked her what her study strategy was. And her study strategy was she would play my lectures and then she would go about her business. She would cook her dinner, she would play my lecture and listen to it and clean her room or clean her house, that type of thing. She was listening to it like you listen to music or a podcast. And it was like, oh, gal, it's no wonder you're not learning the information. She wasn't taking notes. She wasn't taking notes of her notes. She wasn't quizzing herself, on the material in the notes. That's the way you will learn this information. And for those of you personally, and for those of you who are future healthcare providers, I want you all to learn the information in this class. It is going to be very practical for your life, especially if you're a healthcare provider. Other questions?
I do have another question.
Okay.
Actually, it's regarding Corona. So I know we're not told to wear gloves, but would you recommend wearing gloves in public?
One of the things they're recommending that we don't do is wear the same gloves in different stores, because then you could be taking something from Harris Teeter over into Walmart, because it can live on the surface of the gloves. So if you use the gloves, you want to use them once, you want to, just like a healthcare provider, flip it and then dispose of it properly. But again, even if you've got gloves on, if you touch your face with those gloves and your gloves have infection, you're doing the same thing as you're doing with your hands. So there's less recommending the gloves, but frequent sanitizer. Keep sanitizer in your pocketbook if you're, carry one, your car. So anytime that you're out, you've got access to that. Yeah, good question. Anybody else?
I may be missing it on here. I'm looking at your syllabus. But as far as like any sort of like checking for attendance kind of thing, how would that work? It's just based on, okay. Just want to make sure. I didn't think there would be, but I just want to make sure.
I had to post the attendance policy that the university says we're supposed to post, but it's kind of ridiculous now.
That's what it looked like. I was like, this feels like a canned response.
Yeah, it is a canned response. And, actually, even when I had live classes, I did not take attendance, because my thought is, you're adults, I'm an adult, you're adults. If you all want to learn and get your money's worth of a college education, then you come to classes and you learn. I mean, you do the work and you learn. And I always found it I don't even like extra credit, but I do it because we need to populate our subject pool in the psych department. That's why I have extra credit in this class. But as adults, I kind of feel like it's patronizing to you all to take attendance. Like, you got to go to class. It's like, that's your choice. And keep in mind, I mean, as I think about this, people are going to get sick. Some of you are going to get sick from strep throat. Some of you are going to get the virus and be down for a while. I want this to be as flexible as possible. And if any of you, particularly if you have extenuating circumstances or you're sick when the deadline for an exam comes up, contact me and I'll want some explanation, but I'll work with you.
Okay. And then as far as like with exams, like, I'm not like the structure or anything, but I guess would it be more like conceptual type of things? Like, how do you tend to?
The reality of this class is there is a lot of memorization. We can't get around that. I'm not just trying to like put information in your head and it's just useless memorization, but that's the reality. You've got to be able to memorize stuff before you can apply it or before you can start integrating information. The exams are 50 items, multiple choice. You will have 40 minutes to take them, and the 40-minute time limit is because I don't want you all looking up answers for 50 different questions. I want you to have learned the information so that you can take the exam items, and if you have some time left over to look up one or two, you gotta look, you can do that. It's open book and open note because I can't control the environment. So it wasn't open book, open note when I was in the classroom. I used to have y'all take the exam on As You Learn in the classroom, and it wasn't open book and open note at that point. But.
Okay, thank you.
Sure. Anybody else have questions? Okay, feel free to email me. Feel free to email Shraddha. Feel free to attend our office hours on Zoom this semester. Just because I'm not, walking out of the classroom where you can chat with me in the hallway doesn't mean I'm not available, or doesn't mean Shraddha's not available. We are available. We are just all staying home and trying to stay safe and prevent the spread of this nasty pandemic. So I look forward to hearing from you all. I won't be seeing you again in class after today, but I look forward to contact with you otherwise. Have a great semester, everybody. Thanks for participating.
Thank you.
Thank you, Dr. March.
Bye-bye.
Have a great day.
You too.